Thank you for the honor of speaking today to all of you. So I'm going to go through the slides on, preferably on this screen, which is closer to me. Let me see if this works. So I have no disclosures relevant to the presentation today. I think you already received a very exhaustive talk about what periodic paralysis is. I'm just going to do a brief summary about the types of periodic paralysis and similar characteristics of the disease. So periodic paralysis, as all of you know, is autosomal dominant disorder. Two main types, hypokalemic, hyperkalemic periodic paralysis, but we also have Andersen-Tawil syndrome and thyrotoxic periodic paralysis. And there are some specific triggers that, each person has its own trigger usually, and it's usually secondary to mutations in the sodium, potassium, and calcium channels. So periodic paralysis are really a group of what we call muscle channelopathies. All the most common muscle channelopathies are listed here, and periodic paralysis are the ones I have highlighted with a yellow arrow there. So a little bit about hypokalemic periodic paralysis. Usually happens, people have the attacks when the potassium is below normal, usually lower than 3.5, and the first attack occurs in the first to third decade of life, and the frequency of attacks increases in the second to fourth decade of life. And now the attacks can last many hours, and sometimes days at a time. So it can be very severe when people have these flaccid paralysis events. Now, common to all periodic paralysis, the more frequency of attacks is supposed to cause more progressive muscle weakness in the future. So people can have, in the fourth, fifth decade of life, an appearance similar to a progressive muscle disease because they start developing weakness in the hips or in the shoulders associated with a lot of muscle pain and disability with it. Hypokalemic periodic paralysis usually doesn't have any muscle stiffness or myotonia, so persistent muscle contraction after exercise, so they don't have that. And they do have some triggers. Common triggers are carbohydrates, rich meals, so pizza, a lot of bread and things like that. Rest after exercise, and sometimes stress, just emotional stress can trigger these attacks too. Hyperkalemic periodic paralysis, so the attacks are usually occur when the potassium is elevated above 4.5. Again, most commonly in the first decade of life, people have the first attacks. And the attacks are more frequent but shorter in duration than hypokalemic periodic paralysis. So maximum duration usually up to 2-3 hours. People will have some degree of stiffness, or we call myotonia, sometimes between attacks. So that helps us also in diagnosis. We can examine and look for myotonia in the clinic visit. And they can also develop permanent muscle weakness, usually in the fifth or sixth decade of life. They have progressive weakness with muscle pain and disability. And triggers different from hypokalemic periodic paralysis, usually potassium-rich foods, rest after exercise as well, and fasting. ATS, so that's Andersen-Tawil syndrome, is really a combination of three findings or details in the history. One is the flaccid weakness of periodic paralysis episodes. They also can have cardiac abnormalities, usually EKG abnormalities, so electrocardiogram abnormalities, ventricular arrhythmias, prolonged QT interval, and prominent U waves. Those are the specific features in the EKG. And also phenotype, so the appearance of people affected by this condition can be different, not always, but can be different with a little bit of low-set ears, the eyes may be too close in the face, too close to each other in the face, a small jaw, webbed feet or webbed toes, things like that. Cardiac symptoms can present in the first or second decade of life, usually palpitations or syncope, but they can also present initially with weakness. Now, they don't always have all the three features, okay? So sometimes they have just the weakness, so they can look like hypokalemic periodic paralysis patients, because usually the potassium will be low when they have the attack. And they will also develop progressive weakness later in life. Thyrotoxic periodic paralysis is less common. It's usually more common in Asian people or Hispanics, but it's a very common cause of hypokalemic periodic paralysis attacks in that population. Usually the potassium, like I say, is low. Now, when we talk about treatment for periodic paralysis, I have to focus on the medications, but really you have to consider three main factors here. Education, educate the patient about the triggers. Every person, like I say, you have hypokalemic, hyperkalemic, or the other types of periodic paralysis, you have your own triggers, and maybe educate them about them. They haven't recognized what the triggers are. Then potassium supplementation or avoidance will be key, depending on the type of periodic paralysis you have. And then there are specific medications that can help you control the disease as well. So again, talk a little bit about the triggers. Hypokalemic periodic paralysis, usually carbohydrate-rich meals. And why is that? Carbohydrates stimulate the release of insulin, and insulin will promote a specific pump in the cells, usually in the muscle cells, and that pump will pump the potassium from the outside to the inside of the muscle cells. So really your potassium will start decreasing in your serum in the blood. So the total potassium in your body will not decrease, but relative decrease on potassium outside the cell, and that will trigger an attack. Alcohol, usually beer, for example, will have a lot of carbohydrate content and can trigger similar attacks. Rest after exercise, there is a lot of debate on why rest after exercise could trigger hypokalemic and also hyperkalemic attacks, for example. But it changes the pH level. After you exercise, your pH level decreases. If it's a light exercise, usually protective. You can exercise lightly and try to blunt or stop an attack that's coming. But if you have a prolonged period of rest, the pH will recover, and that may trigger an attack also on hypokalemic periodic paralysis. Emotional stress perhaps has to do with release of adrenaline. Adrenaline can also play a role in changes in pH and potassium. Pregnancy, cold temperature, that depends on the mutation you have, because some mutations are more temperature sensitive as well. For hyperkalemic periodic paralysis, potassium-rich foods, for obvious reasons, you eat more potassium, potassium will increase, and you'll have an attack. Alcohol, again, it usually has more carbohydrate content, but there are some reports of people that alcoholic beverages and hyperkalemic periodic paralysis are not compatible. Fasting probably has to do with prolonged periods of fasting. It's the opposite than eating hard carbohydrates. You have less insulin and actually promote the release of hormones that may increase the potassium in your serum. And rest after exercise, again, there's not a good explanation for that, because usually it's correlated with hypokalemic periodic paralysis. But there are case reports of rest after extreme exercise. Usually the next morning, then people with hypokalemic periodic paralysis will have an attack, and they wake up and they're paralyzed. Pregnancy and cold probably had to do also with the type of mutation you have and also hormonal changes. So some potassium-rich foods, I think you have already talked about nutrition and periodic paralysis, so this is probably going to be very redundant, but all of these, you can look online, and these are foods with high potassium content. And the ones I highlighted actually surprised are the ones that have more potassium content. I thought bananas would be the top of the list, but actually sweet potatoes have more potassium than bananas. Beans and legumes the same. So a little bit about potassium supplements. Those are very conservative strategies. Not really prescribing medications, but just some potassium supplements you can use if you have hypokalemic periodic paralysis to prevent, sometimes to even treat an attack, or decrease the intensity of the attack. There are different formulations of potassium. I think the most commonly known are going to be FRK, which is potassium citrate or bicarbonate, and there is also chlorcon, which is potassium chloride. So you dissolve them, usually in about 120 milliliters of water, and that will give you 20 milliequivalents of potassium. Okay? And like I say, you can use that as a prophylactic 1 hour or so before exercise, before heavy exercise, and that may prevent an attack as well. And this is for use, obviously, in people that have hypokalemic periodic paralysis. If you have hyperkalemic, you don't want to take extra potassium. And ideally, you shouldn't consume more than 100 milliequivalents a day. Some textbooks say 200 milliequivalents a day, because you don't want to increase your potassium for too high. High potassium can also be toxic, especially with the cardiac effects. And there are also some sustained release tablets. So these are more immediate release, but there are sustained release tablets you can use the night before, especially if you have a lot of morning attacks. So that's more helpful to prevent an attack in the morning. Focusing a little bit now on prescribed medications. So medications you go to the doctor, and he writes a prescription for you to take to prevent an attack or to treat an attack. The two most well-known are acetazolamide, so Diamox, and diclofenamide, which is Kevages, that you already just had a panel about it. So the class C, that applies to pregnancy. class C and acetazolamide, so I think that means there are some potential teratogenic effects in animals, but not proven in humans. Diclofenamide and other carbonyl anhydrase inhibitors, such as topiramate or sonizumab, they have it's not a black label, but a questionable use in pregnancy. So you usually avoid in pregnancy, or you use it with caution. And there's some pregnancy registries I think you can register if you're going to take it, so you can have follow-up after delivery. The action mechanism in periodic paralysis is really unknown. It may have to do with excretion of potassium in urine. So you have hyperkalemic periodic paralysis. Well, these are really a little bit of water pills, so it makes you lose potassium. So you have less potassium in your body, so that can help. But it's also helpful in hypokalemic periodic paralysis. So that may have to do with a change in pH, producing a little bit of acidosis. And that can also be helpful in most patients with periodic paralysis. A relative contraindication for both of these medications is the sulfa allergy. So people that have allergies to sulfa, so Bactrim, for example, there can be some cross-reaction. And looking at the literature, really there is not a 100% correlation. You have a sulfa allergy that you will get the same reaction with these medications, so it's really a low risk. But it's something to keep in mind. If you're going to take it and you have an allergic reaction to Bactrim before, use it with caution, maybe under supervision. So what are common side effects of these medications? I think some of them were already mentioned by the panel. Paresthesias, which is basically tingling, pins and needle sensation around the lips, the fingers, the toes, different parts of the body. And this is reversible, and sometimes it's depending on the dose. So you go to a higher dose, you get more of the symptoms. Some people tolerate them well, and they're like, okay, it doesn't bother me too much. Some people find it very annoying, and they cannot take it, and they have to stop the medication or decrease the dose until a tolerable level. But it's reversible. So you stop the medication, it will go away. So it's not permanent. There is not sign of permanent nerve damage or anything like that. It can cause fatigue, which is usually mild. There is some reversible cognitive problems, like people feel a little foggy, maybe have some trouble concentrating or confusion. Again, that's depending on the dose, and some people tolerate it better than others. Kidney stones, again, I have percentages and other slides. I think it's less than 10-20% of people. And obviously the risk is higher if you already have a risk of, or a history of kidney stones, so multiple kidney stones. This medication may be relatively contraindicated. You have to be aware that it may increase your risk, especially you get very dehydrated. So you have to drink a lot of water to keep the flow of urine moving and reduce the risk of kidney stones. An important detail is in hypokalemic periodic paralysis. In the first two slides, I mentioned the different genes causing periodic paralysis. So hypo-PP, there are two main genes. One is the calcium mutation, and one is the sodium channel mutation. So most common will be calcium mutation for hypo-PP. But people with sodium channel mutations, hypo-PP, may be a little less responsive to carbonyl anhydrase inhibitors, especially acetazolamide. And there were a couple of studies, they described that most people with a calcium channel mutation responded to acetazolamide versus the sodium channel mutation. And this depends really on the type of sodium channel mutation they had. But in general, about 50% of people responded to acetazolamide as a group, but only 16% of people with the sodium channel mutations did. So if you had a low response to acetazolamide, because sometimes physicians start acetazolamide from the get-go because it's cheaper as well, you didn't respond, it may be maybe you have a sodium channel mutation. And also the specific type is important. That's something to keep in mind. About Cabella's diclofenamide, so it's 30 times more potent than acetazolamide, so you need less of a dose to have an effect, really, and 5 times more potent in vivo. There have been 2 to 4 randomized controlled trials, really, including patients with hypo-PP and hyper-PP. The number of patients is included there, so about 130, 140 patients total. And they treat them for 9 weeks, and they follow 61 weeks, so a little more than a year follow-up. And there was a reduction of attack rate, so the number of frequency of attacks reduced, and also the severity. And even improvement in quality of life, especially in people with hypo-PP. Side effects, like I mentioned before, common side effects is tingling, so paresthesias is up to 50% of the patients total. 20% reported some degree of cognitive symptoms, like maybe feeling a little slow or foggy. Again, those are reversible side effects. This Jeusha has to do more with taste, change in taste. So sometimes they have this metallic taste, or they try to drink soda, doesn't have a taste anymore, so they don't like it. So it can cause also a little bit of weight loss if you stop drinking soda, actually helps. But that's another side effect that some people don't like, the metallic taste in their mouth. And kidney stones or nephrolithiasis, 3 to 20%, depending on the study of the type of patient we're talking about. Again, usually more often in people that have history of kidney stones previously already. And the dosing usually starts at 50 milligrams once or twice a day, and then you slowly increase up to maximum 200 milligrams a day. It depends on patient tolerance, side effects, and response. It's recommended to monitor for a level of pH you're having, so acidosis really bicarbonate, because if you get too acidotic, it may have some other effects that you don't want. So we can do some periodic blood work every 2 to 4 weeks, especially at the beginning. Once you get to a good dose, you don't need to keep monitoring that often. Talking more specifically about hypo-PP management. So what happens during acute attack? So some patients feel the attack coming, right? Sometimes it happens without warning, but most patients, I think, have some feeling that the attack is going to come, some warning signs, some muscle pain or paresthesias, or something that tells them, okay, unfortunately, I'm going to have an attack. So some people can stop the attack with mild exercise. So walking around a room, shaking the arm, shaking the leg at the onset of the attack could abort or lessen the severity of the attack. So that's important for people to try or educate them. Then obviously these patients have the attack because potassium level is low in serum. It's important to remember there is not a total deficit of potassium. So the total potassium in your body is normal, but there is a relative drop in the level of potassium in the blood or in the serum. So you want to administer potassium, but don't give it too much, because then that can cause some problems. So oral potassium is preferable. So we can use that dose, 0.4 milliequivalents per kilo every 30 minutes, the maximum of 200 to 250 milliequivalents a day. Usually the liquid formulation is best absorbed and faster in action. Usually you get a response within 30 minutes. And now for severe cases, or maybe people cannot swallow, or there is no access to the oral potassium, then IV potassium could be recommended. But again, IV potassium is highly risky because your potassium will increase really fast. And remember, there is not a deficit of potassium total, so it will go too high. If you shoot up too much, you can have cardiac effects, even life-threatening. So it's recommended to have some EKG monitoring going if we're giving IV potassium. And IV potassium should be given in a mannitol solution. So mannitol is not an electrolyte, it's more like it's a carbohydrate of some sorts, because you don't want to give extra salt, which actually may cause worsening of the attack. And then, again, you avoid sugar or saline containing IV solutions, because that can actually make the attack worse. So prevention of the attack in hypo-PP, low sodium and low carb diet. So that's important. I think you talk about nutrition in periodic paralysis. I'm sure they talk about this already. Avoid triggers, avoid high carb meals, high salt meals, alcohol, stress, other triggers you have identified, try to prevent them or avoid them. And daily slow-release potassium tablets are important. Those 30 to 60 milliequivalents a day. So not a liquid formulation. A liquid formulation is more like fast action, right? But you can get a slow-release potassium tablets, just 30 to 60 milliequivalents a day. So just to keep your potassium perhaps a little bit above your baseline, and that will try to prevent the appearance of an attack. Now, along with the slow potassium release tablets, you can also use carbonic anhydrase inhibitor medications. We already talked about acetazolamide, diclofenamide. Those are the doses. 50 milligrams twice a day, usually starting. Sometimes people start at 50 milligrams once a day for Kebeyes, and then you can go up to 200 milligrams a day. Acetazolamide can go up to 1,000 milligrams a day. And there are some case reports in which they give acetazolamide to patients with prolonged history of hypokalemic periodic paralysis weakness, and at least one patient has some reported improvement in muscle strength even after receiving medication after many years. So some degree of muscle improvement can be, muscle strength improvement can be expected even after prolonged duration of disease. Now, the strategies to treat hypokalemic periodic paralysis, focus on keeping your potassium level high. So we have potassium slow release tablets, we have the Kebejis or acetazolamide, but you can also use water pills that help you keep potassium in your body. So this potassium sparing diuretics. So instead of making you lose potassium in the urine, these tablets make you, keep the potassium. The potassium gets reabsorbed in your kidney. So those are the most commonly used medications. Eplerenone has less anti-androgenic effects, so probably preferable, especially in male patients. Spironolactone, so that's aldactone. It can have some anti-androgenic effects, so not really recommended in males. Triamterene. And if we are using these medications, we want to check the potassium level intermittently, initially every 4 weeks, and then perhaps every 3 months, just to make sure you're not keeping the potassium too high. Because again, high potassium, hyperkalemia can also have its own problems. Now, what about hyperkalemic periodic paralysis treatment? So acute treatment, again, you feel the attack is coming, you have some warning signs, it's okay, I'm gonna have an attack. Mild exercise is also recommended. So the same as hypokalemic periodic paralysis, mild exercise, moving around the room, shaking the leg, shaking the arm, could be helpful. Carbohydrate snacks, again, increasing the sugar will increase insulin, and the insulin will promote potassium moving from the outside of the cell to the inside of the cell. And that can also decrease your potassium level outside, so will decrease the potassium level and prevent the attack. So it's recommended that people carry around with them, some carb snacks in case they have an attack or impending attack. Beta agonists, so salbutamol, so this is the inhaler that people with asthma use. You can use 1 to 2 puffs. It also has the same effect as insulin. It will promote the movement of potassium from the outside to the inside of the cell. This is a short time effect, obviously, but it can help you abort the attack if you use it very early. So other strategies for prevention of the attacks include, again, multiple small carb snacks, sometimes space out the meals, every 3 to 5 hours to prevent prolonged periods of fasting. Avoid high potassium foods. And then you have the Kebejis or Diamox medications that can also be helpful in people with hyperkalemic periodic paralysis at similar doses as hypo-PP patients. Other strategy for prevention. So for hypo-PP, we use these medications that help you keep potassium from the urine, right? You reabsorb the potassium in the kidney. So in hyper-PP, you actually want medications that make you pee more potassium, make you urinate more potassium. So thiazide diuretics, this is water pill that makes you lose more potassium. So you can use that to decrease your potassium level in the body. And then obviously avoid potassium sparing diuretics because that actually is counterintuitive. Your potassium will increase. You don't want to use that. Andersen-Tawil syndrome, similar strategies for during the acute attack. Mild exercise can abort the attack or decrease the severity of it. And then the rest of the treatment really will depend on the potassium level. So most patients with ATS will have low potassium. So you use the similar strategies as hypo-PP treatment. But if you have the high potassium, then you want to actually use carb snacks, for example. You want to monitor the EKG. These patients have an arrhythmia underlying, so you want to monitor EKG and the potassium, obviously. Acetazolamide and diclofenac are also recommended. Specific notes about this group of patients are preferably avoid salbutamol because it can exacerbate arrhythmias. It's a beta-adrenergic agent, so it can cause more tachycardia, more arrhythmias. Thiazides could make you lose potassium, so it can worsen the low potassium level, and then that can actually make the EKG worse. In asymptomatic patients, so patients that in between attacks, it's recommended that they have a cardiology follow-up, obviously, at least once a year, with EKG and Holter monitoring. And they should have cardiologists in charge of the antiarrhythmic agents, medications. Some of them are here. Flecainide is the most commonly used, I think, but you can also use other beta blockers, calcium channel blockers, and amiodarone. For TPP, so thyrotoxic periodic paralysis, so these are patients that have an attack usually in the setting of hyperthyroidism, so too much thyroid hormone in their bodies. And they usually have low potassium level during the attack. So they behave like a hypo-PP patient. They have a different type of mutation though, but they would require potassium supplementation. Also propranolol is a beta blocker because during the thyrotoxic attack, the adrenaline effect is really heightened. So you want to block that effect to reduce the severity of the attack. And then the mainstay treatment is really abortive thyroid treatment. So you want to use antithyroid medication or radioactive iodine. Once that thyrotoxic storm is stopped, the attack stops as well. Now to finalize, I mentioned briefly that people with hyperkalemic periodic paralysis can have episodes of myotonia or basically delay muscle relaxation after contraction. And this only happens in hyperkalemic periodic paralysis and also obviously in paramyotonia patients, which is another type of channelopathy. And these are some of the medications that are recommended for treatment of myotonia. They are all basically sodium channel blockers. So mexiletine, lamotrigine, ranolazine, and flecainide. Mexiletine, I think, is the kind of first-tier, first-line medication. It's also an antiarrhythmic. Lamotrigine is a seizure medication. It's also used for myotonia. Ranolazine is anti-angina, so cardiology medication, cardiac medication, and flecainide also antiarrhythmic. So they really don't have a lot of a role in periodic paralysis treatment. I think lamotrigine has been tried before. Not much the other ones, but mostly for myotonia. And that was all I had to cover. Thank you.
Okay, and we'll have questions for Dr. Chuquilin. You're welcome to come up if you're here, or if you're remote, you have one. Yeah? Did you have one? Okay. You want me to bring you the mic?
Hi, I was just curious because I do F4K and the powder chlorcon. The pharmacist said it should be the same, but I feel like F4K is faster. Is that true, or?
I think they're equivalent. Actually, my review says that chlorcon may be a little faster, but I think every person has different responses to medications. So you found F4K more effective.
I feel like it is, but I was just curious if you saw a correlation or.
Not really.
I like F4K better. That's why.
You have a question?
Hi there. My daughter takes F4K in the tablet form. Does it really matter how much liquid she's dissolving that in?
The effervescent tablet?
Yes, the effervescent.
Yeah, usually 120 cc is recommended, I think, to improve the taste as well. But how much is she dissolving?
She does not like the taste of it, so the
minimal
amount of liquid is what, like this in a tiny cup.
Okay. Yeah, I mean, you don't have it all dissolved, so it's not, the liquid formulation is not, as it's supposed to be. So the action, the onset of action may be delayed, but the total amount she's taking is the same.
It's the same. That's what I wondered, because you said
so it's probably the same. It just may not be working as fast as it's supposed to.
Thank you.
Okay, this was a question that came in on a note. It says it's a male hypo patient. This person is taking 50 milligrams of Keveyis twice a day, 40 milliequivalents of potassium twice a day, 20 milliequivalents more potassium with weakness or dog alerts, 25 milligrams of eplerenone, am I saying that correctly? Twice a day. Because of POTS, can't increase eplerenone because it drops blood pressure. The potassium is making me sick to my stomach, so I don't want to increase. Is there a different potassium-sparing diuretic that does not lower blood pressure? So I'll ask that, and then I have a follow-up.
I would probably suggest, all the the ones I mentioned, they drop the blood pressure. They're potassium-sparing diuretics, so they will cause drop in blood pressure. But maybe there's room to increase the kVh's dose, the diclofenac. It's 50 milligrams twice a day, so we'll probably increase that dose instead.
Okay, and then the follow-up, would you recommend increasing dichlorphenamide?
Right. So
Okay,
that
there
would be
you
my
go.
recommendation, yeah.
Okay.
Yeah, exactly.
Very good, thank you. More questions? With hyper PP, if surgery is being planned, should we ask that any IV fluids given not include potassium?
With hyper PP?
Hyper PP, they have a hyper PP, and if their surgery is being planned, should we ask into presumably the hospital that any IV fluids given not include potassium?
Correct, yes. You should avoid potassium-containing solutions if you have hyper PP in the surgery, yes.
Okay, very good. Do we have any others? And there's one from the audience. Any contraindications for medications with hypo-PP with a low bicarb level of 14?
So I'm assuming the bicarb level is low already before starting treatment. Yeah, I mean, that will be a relative contraindication to use acetazolamide or kVh's because they can lower the bicarbonate level even more. So maybe focus on potassium-sparing diuretics or just potassium supplements, especially if this hypo-PP patient. That's what I would do.
Okay. And any others? You got one?
Hello. Everything about all this has to do with a really big balance for potassium, sodium, back and forth. I have paramyotonia, so I kind of am stuck with both at different times. I live in the South. I can get really overheated, like another gentleman's been talking about. For rehydration purposes, when like being super dehydrated, your kidneys are being affected, if my potassium is so far been staying at a normal area, where should I be moving my concentration to? Like, I don't want to just have straight water. I need to increase my electrolytes as well to combat that dehydration. What's going to be the better option for me if I don't want to just take a whole bunch of potassium, magnesium? I need to balance it out.
So you notice that your potassium is usually low or high? Or?
It's normal.
Normal.
Yeah.
But if you get dehydrated, you have an attack? Is that what you notice?
I haven't quite been able to pinpoint different things. I have a lot more muscle contractions. I can cause myself to have a attack of weakness by doing a lot of exercise. I can force that, but I also do have a lot of muscle crampings, and I haven't been able to pinpoint what causes the cramp. I haven't been able to find my triggers for that yet. And everything is, talks about the hyper K part of everything. And if I'm trying to hydrate, potassium is a big part that's included in anything that if I'm trying to look at electrolytes and not just water replenishment.
So if you have just paramyotonia and not the hyper-PP component of it, then potassium level doesn't play too much of a role there.
Okay.
So you can start hydrating with just regular, water, unless you have Gatorade or other things, and see how you do. If you notice, my attacks are actually becoming more often, I drink this Gatorade, then maybe you just need regular water, because the potassium, as long as your kidney is functioning properly, your potassium level will remain normal, and it shouldn't affect the paramyotonia component of it. Paramyotonia is usually triggered by cold or frequent exercise, repeated exercise, right? And you have to rest after exercise. So those are different from dehydration. Then medications, I don't know, you're taking any medication for the paramyotonia? No?
I just found out last year that I had this.
Okay, I mean, the attacks are frequent. You can also use medications to help you. The last slide, some of those mexiletine or lamotrigine can also decrease the frequency of attacks. You could maybe even tolerate more exercise when you're taking these medications.
Sure.
Does gabapentin treat periodic paralysis? I have hypo and I take it for pain, but I think I've heard somewhere that it might also help. HKPP, is that hypo? Hypo, yes, hypo.
I haven't read a lot of case reports on gabapentin and periodic paralysis, but it may be anecdotal. Gabapentin works in GABA receptors, which are different from the sodium and potassium receptors we talk about here. But it may be just a different, mechanism.
This is one from our online audience. I have to go into the ER periodically for IV fluids because of Addison's. I am hypo-PP. What type of IV should I get?
So the person goes to ER for IV fluids.
They go to the ER periodically for IV fluids because of Addison's.
Addison's disease.
They have hypo-PP, and they ask what type of IV should they get when they're going for those fluids.
Well, if the person is not during an attack, and is going just for Addison's, which is, I'm assuming, is getting IV fluids because of the low blood pressure drops in Addison's crisis. So it shouldn't. It should receive sodium chloride. If you don't have an attack, I don't think it will affect it, because potassium chloride really doesn't make too much of a sense. If your blood pressure is dropping, it may not raise the volume, the blood pressure. So we'll just give sodium chloride and monitor.
Okay, some more from online. They're probably catching up from this morning. Are there any medications for hypo-PP that can be taken while pregnant or trying to conceive?
For hypo-PP, well, like I mentioned, acetazolamide is class C, so it's not really contraindicated. But there's some reports that it could be teratogenic in animals, but not proven in humans. So that's one medication that is not relatively 100% recommended, but is relatively safe. And then the potassium supplements, the diclofenac or other seizure medications I mentioned, they are relatively contraindicated. So I wouldn't use the other ones.
Okay. This person says, I've been under the impression that I had hyper until a recent genetic test told me I actually have ATS. I have been taking acetazolamide for 40 years. Would I benefit from switching to Keveyis?
I think it depends on how that person is responding to acetazolamide. If the attacks are controlled and she's doing well on acetazolamide, I don't see any reason to change, because the mechanism of action is similar. Sometimes Keveyis can be more effective in terms of side effects, potency, but the person is responding well to Diamos, then no need to change.
What would be your recommendation for a maximum dosage of F/K per day, and how far apart should doses be taken?
So recommended is 200 to 250 milliequivalents a day. Each tablet has 20, so that makes about 10 of those tablets a day.
This one says hyperkalemic PP with myotonia. They have the SCN4A VUS. Is there a reason that Diamox and tapering off a short course of prednisone would create permanent weakness within hours, but potassium does not? It seems like all three are increasing potassium, but I do recover from taking Kiltcon or eating a lot of potassium. I don't recover from tapering off prednisone or taking Diamox. And I do realize that none of these are suggested for hyper.
So if I understand, the person has more weakness when he takes prednisone taper, and what was the other one?
Yeah, so that it seems like all three, I recover from taking the Kiltcon or eating a lot of potassium. I don't recover from tapering off prednisone or taking Diamox. And this is a hyper.
Okay, well, I don't have really a mechanistic explanation for that particular response. There's not really a mechanism of action that will explain why you recover one versus the other. A permanent weakness usually takes years to develop. It won't develop in hours.
Okay. What is the quickest way to recover from an attack to keep from long-lasting cramp or weakness? I need to return to the game. Thanks.
The quickest way to recover from an attack?
Guess so. This is someone who wants to get back in the game. This is, what is the quickest way to recover from an attack to keep from long-lasting cramps or weakness?
Okay, well, if we're talking about, hypo PP will be, potassium supplements, and basically it's just trying to prevent the attack from happening, right? Getting the potassium level where it's supposed to be. Maybe we're using some of these diuretics or medications, carbonic anhydrase inhibitors, trying to prevent the attack from happening. Once the attack is set, then it may take hours to recover.
There's not a quick start way to recover.
Yeah.
Okay. I have hyper PP, and I take acetazolamide, but when I tried adding hydrochlorothiazide, it lowered my blood pressure too much. I struggle with dehydration and low blood pressure because of other chronic issues. Any suggestions for meds that won't exacerbate these issues?
Okay. Well, you say the person takes acetazolamide already?
They're hyper, they take acetazolamide, and they tried adding hydrochlorothiazide.
So my suggestion would be perhaps to change acetazolamide to diclofenac because it has a more potent, may require less of a dose as well, and maybe more tolerated.
Hi, my son is 6 years old. He was clinically diagnosed at 3. He takes acetazolamide, 125 milligrams, and he's doing okay. Sometimes he's on and off for a couple of weeks, but then he'll spend a couple of months without anything. My question is, in terms of all of these medications and dosages and stuff like that, are your recommendations different for children?
Yes, the dose is probably different. I don't have it on top of my head, but yes, the doses will be different, pediatric doses. Depends on the weight, really. Once you get 12, 13 years of age, then you get adult doses, but under that age, it would be a lower dose, yes.
Okay, and for any of the other medications you were talking about, are they okay for children, or?
Which one's the last slide?
Yes.
So your son has hyper PP or
No, I'm sorry. He has hypo.
Hypo PP.
But for Kevacys or any of those, or even the doses around how much potassium to give him if he does have an attack, is it a different dosage? It's all depending on weight, or?
Yeah, I mean, I will start,
Are they okay for children, or is it different?
No, I will start with one tablet, FRK, the FRK you're talking about. The FRK, I will just give one tablet and 120 milliliters and see how he responds. Kidney can manage a lot of potassium fluctuations as long as the kidney function is preserved. And it will just depends on how much lower his potassium level is. When he takes one pill, he will get up to a certain level. It may go higher because he's taking more for his weight. But as long as his kidney is functioning well, it shouldn't be toxic unless he takes 3 or 4 tablets at once. One tablet, I think he can manage. Yeah.
Okay. Thank you.
Okay, and let me ask you one more question, and we'll have 2 more that didn't get answered on this round, but perhaps they can grab you at the side as we wrap up. This is a follow-up on the IV question for Addison's. If the potassium is low, would you still just do normal saline, or should potassium be added to the fluids?
Oh, if the potassium is low, then I will add potassium to the fluid for sure, yes.
Okay, and with that, let's thank Dr. Chuquilin, please, for a wonderful talk.
If you would like to know more about periodic paralysis, visit periodicparalysis.org. And if you enjoyed this video and want more, hit that like button, subscribe to our channel, and hit that bell so you don't miss any future videos. It really does help spread the word. You can view other videos about periodic paralysis by clicking the thumbnails to the right. If you have questions, just leave a comment below or reach out to us on social media. We'd love to hear from you.